So if you're a physical therapist working with a patient and you're currently struggling to help them get out of a posterior pelvic tilt, or if you're a patient yourself and you're stuck in a rounded over posture and you can't seem to find something that works, then this video is for you. What I want to do in this video is share my simple guide to fixing a posterior pelvic tilt. So to fix a posterior pelvic tilt, we first need to discuss the traditional approach versus the redefined approach. The traditional usually leads to short-term results. The redefined approach, which is the framework that we're going to talk about through this entire video, usually leads to long-term results. So within the traditional, the go-to treatment usually is stretching. Why? Well, normally when we walk in, we see our patient in this rounded over position. We then like to label things as tight and then stretch them. Now, I don't have a problem with stretching. The thing that I do have a problem with is when we start to think that stretching is going to give us that long-term result. Ultimately, stretching a chest and stretching a back feels good and is going to provide short-term relief. And that's totally okay. We just have to be the mindset that that's what we're going for. The main goal that we're going for is that short-term relief. Or we just did something, we're trying to move into that new motion, right? And so stretching isn't the problem. It's usually the mindset that we put as it relates to stretching. So that's the traditional approach. The redefined approach is driven by trying to change a pattern. When you can change a pattern, you just gave that patient long-term results. Why? Well, they are moving in a completely different way. They came to you with a certain pattern, right? This kyphotic pattern. If you can change that kyphotic pattern, you just fixed the problem. You gave them a long-term solution. With the stretching, when we're in this kyphotic pattern, we start doing chest stretches. Again, does that really change their pattern? Not really. And so when it comes to the redefined approach, we are taking a step back, we are understanding the human body, and we are asking how can we disrupt their pattern. The second we can do that, we start to give long-term results. The only way we can first do that is by understanding the biomechanics. So when it comes to biomechanics, I'm not going to bore you to death, but what I do want to do is hopefully provide a more simplified approach to understanding the biomechanics to then relate them and bring them into your treatment. I think that's the problem when it comes to biomechanics. They can be complicated, but there's this wall that makes it really hard to transfer into our exercise selections and our treatment. So hopefully after this short clip, you can have a better understanding of that. So from a posterior pelvic tilt, that kyphotic posture perspective, the biomechanics are as follows. Sacrum is in a counter-nutated bias position. The innominate bones are in external rotation, abduction, and flexion. What does this result in? This results in our normal rounded over posture. The way I like to describe this is the no butt syndrome, right? This is when the sacrum's in so much counter nutation, it's going to dump this whole pelvis back, and it's going to give the appearance that someone doesn't have a butt. They do have a butt, it is just tucked under, right? And so from a biomechanical standpoint, that's great. We understand it. But let's actually put it in a way that makes sense, right? The thing I want you to really understand is compression and expansion. If you can think of compression and expansion when it comes to biomechanics, you should have a better understanding as to what the next best step for you to take. So we already said this is counter nutation, right? Well, what does that mean? Counter nutation is compression. And so this whole backside is compressed. And it makes sense because it turns the whole pelvis in this posterior orientation, right? Muscles have to do that. And they do that by compressing. So we have compression posteriorly and expansion anteriorly. What does this continue to mean? This means that the pattern of this individual in front of you is compressed back here and expanded back here. What did we say the redefined approach does? We said that it changes patterns. So if the normal is compression, expansion, all we want to do is start to compress and expand. So now that we understand the biomechanics, we can choose exercise. Not only can we just choose exercise, but we can do it in an intentional way. Instead of giving someone a random pec stretch to get them out of their kyphotic posture, we are now utilizing principles based on the person's anatomy and biomechanics to change their pattern. This is the difference between short-term versus long-term. So with that said, I quickly want to go through 3 exercises and progressions that you can use to help get your patients out of this posterior pelvic tilt. The first exercise is a hanging dead bug. Now, really what this is all about is improving awareness of the pelvis and improving awareness of breathing. When someone is stuck in a big posterior pelvic tilt pattern, chances are their awareness of the pelvis is going to be significantly limited, and also their breathing patterns are not going to be normal. So in a hanging way, it just drives a ton of extension and allows us to get more motion, which helps them really understand the pelvis and the rib cage. So all we do is we start just like we do on the table. The only difference is the table now is not limiting their ability to move the pelvis. So if someone's really rounded over, this is a great way for them to move through a little bit more range of motion compared to on the table. The other nice thing is the ability for the chest to start to open up. Right? And so when we start to instruct them on breathing patterns, we're in a much better position compared to them rounded on the table. So again, rib cage or breathing awareness as well as pelvis. The actual exercise can really go as much as it needs to or as little as it needs to. If they just want to be here and hold a neutral position, great. If you want to start to work on bringing the legs off, just like you would do on the table, great. The thing is, increase their awareness of where their pelvis is in space and let them kind of sit into this extension biased pattern. The second exercise is just a hinge to the wall. Now, when it comes to hinging to the wall, I know it's a popular exercise and a lot of people like to do it with the stick above the head and on the back. The problem with this is someone that's in a really rounded over kyphotic position is that this is probably not going to work. What is going to be more important is for them to understand what's going on from their pelvis perspective. And what the wall does is the wall gives them that reference that they're actually hinging, right? Because someone that's rounded over, they're gonna wanna move away from the wall. They're gonna wanna move this way. So what I like to do for someone in this pattern, instead of giving them that dowel, I like to have one hand on the belt buckle and one hand on the back. And all we're doing is having them feel their hips going back. And what I want them to do is I want them to stop if they start to either feel themselves go into that posterior pelvic tilt or if they feel their knees start to go forward. So there's really one key thing they need to do here. They need to be able to hinge back, being aware of their pelvis while feeling a hamstring stretch. If someone doesn't feel their hamstrings as they're going into this, it's because they're squatting. They're way too flexed through the knee. So what we need to do is to make sure we're far enough, have awareness, push back. When they touch the wall, ask them, do they feel their hamstrings? If they don't, they probably need to slowly slide up a tiny bit, and then they start to feel the hamstrings. So again, work through this as a progression to that dead bug and get them really understanding how to hinge. Why? Hinging is going to expand posteriorly and compress anteriorly. Our third exercise would be any sort of progression compared to what we just did on the wall. So any sort of progression as it relates to a hinge. As you can see here, I have a trap bar deadlift, I have a kettlebell for a kettlebell deadlift, and I'm also going to talk about a good morning. The key thing here is not the exercises themselves. The key thing is the principles. Why? Because I'm making a video where many people will see it, but I don't know what that patient looks like in front of you. You ultimately have to determine which exercises are best. The only way you can really do that is if you go and base it off the principles. So what I like to do in my head as to choosing the correct or incorrect exercise is ask myself, where's the compression and where's the expansion? And we mean that, where is the compression and expansion from the patient's pattern, and then how do I want to change that, and does the exercise do that? So let's talk through those three exercises so you can understand this kind of progressed outlook. So with the trap bar deadlifts, great, right? We're hinging into the pattern where we're getting more expansion posteriorly and compression anteriorly. The one downfall to a trap bar is that it's going to promote a little bit more of a squat. A lot of times people don't hinge correctly. They really go into this kind of squat type pattern. Remember, once we start to squat, we're now compressing and going towards their pattern that we're looking to get them away from. So is this a good exercise? Maybe, maybe not. If you can get a nice looking hinge out of here, it is great. If they can truly go back, feel the hamstrings, move into that space, perfect. If they're moving through this as a squat, then it wouldn't be the best exercise. Maybe you want to then try a kettlebell, right? Kettlebell's great because it's an anterior load, which helps them really sit back. Again, anterior load, you just have to make sure that it doesn't collapse them into their pattern, right? So it comes down to really understanding that good hinge mechanic where we're pushing straight down with that anterior load, feeling the hamstrings, not squatting it. Lastly, a good morning, right? A barbell on the back, pushing the hips back. Is this good? Is this bad? Well, a good morning's really great. Why? Well, it's driving us through a ton of extension like we're trying to get through. We're hinging back. We've talked about that enough. But also when you add in the barbell component, specifically in the back, it starts to pull this person into a little bit more of extension. Again, is it good? Is it bad? It depends on the person. Can they tolerate that much of an extreme range? Or are they so far forward that that's just going to be too much? That's why it's hard to give you the best exercise. But what I can give you are the principles, the guides that can help you get to the best exercise for your patients. So I hope you found this guide to helping your patients get out of a posterior pelvic tilt helpful. And if you really want to continue your learning on this, and not just the posterior pelvic tilt, but the principles to change patients' patterns, then I would encourage you and invite you to check out the Performance Redefined course. I will leave the link in the description below, but this is our self-paced online course that goes through this in much more detail and addresses all sorts of patterns, so that way you can continue to getting the best results possible for your patients.